Well, why don't we go ahead and get started? Thank you everyone so much for participating in our Q2 provider network training. Very excited to have all of our participants on the call today. And as always, really want this as an opportunity for our team at CCHP to really share information, answer questions, and provide feedback through this provider network training. So of course, our structure and our agenda is very fluid, and we always depend on feedback and your responses and thoughts to really help continue to make this a meaningful time for us to share information with our providers. So again, and for those of you who don't know me, my name is Irene Lowe. I'm our Chief Medical Officer here at Contra Costa Health Plan. And of course, I want to thank all of our providers on this call for helping us to continue to provide quality health care for our members. We really appreciate everything that you do. And really, I always look forward to this opportunity to really see some of our providers, at least on screen. And I'm hoping that, I'll be able to meet a lot more of you in person as time goes by. So thank you again for all that you do. So I'm very excited to share with everyone that our guest speaker today is Dr. Wortman, a clinical neuropsychologist, and they will be speaking about navigating ADHD and integrating neuropsychological assessment into primary care. So very excited to have them here. So I'll turn it over to Dr. Wortman.
So
let me just make sure your slides are uploaded. Isa, can you just make sure the slides are up?
Yes, they are.
Oh, I don't see your screen.
Okay.
Okay. Well, while that's happening, I'll just say hi to everyone. I'm really excited about this opportunity to meet with everyone today. I get to see all these great cases, and I know you guys are the front line for my job. So I really welcome the opportunity to touch base with you guys. And I'm hoping that by highlighting ADHD, we can talk about the diagnosis, but then also how I operate and how I can be useful to you and your service. And because you guys really have these short visits, and how to really capitalize on somebody like me who I have really long visits with the patients. So do we have the, oh, there's our PowerPoint.
Next slide. Okay, great. All yours.
Okay, am I allowed to shift through the slides, or I just say next slide?
If you could say next slide, that would be great.
Okay, got it. All right, so given this is 20 minutes for me to speak on ADHD and neuropsych in general, I'm not going to cover everything. And what I have here for you guys is not meant to be, the end all be all, but it's a conversation starter, a glimpse into what I do. And so I might make comments that are a little bit deficit based. That's not really my approach. I try to be strengths based, but I need you guys to know what I'm looking for. So I'm going to be focusing more on that piece of it. So I'm going to be explaining about what neuropsych is, what I do in my job, and then I'm going to be talking about the ADHD diagnosis. I'll be giving you some case examples and some resources. So if you have the PowerPoint, they should all be clickable for you guys. And then for you guys, how is this going to be used? When you see these cases in primary care, how to refer to me, and what that should look like. So let's start off with the take-home point. So then as you're thinking about this, how can you apply this to your work and day-to-day life? Okay, so a lot of times when we get these types of referrals, the urge is to send them straight to me, when it might be better met by the mental health team, or inquiring about other needs that they need met, because there's a lot that goes into neuropsych testing. So we really want to know what their daily life is like, their actual function impairments are. And then what I want as a clinician is to know, what do you need? How can I answer your question? So that's really a lot of times the thing that I'm wondering. How can I help you communicate with this patient? Okay. So the main thing is, if I never see a referral that says they think they have ADHD again, I'll be a very happy person. So it's not about me, but it's about the patients. How can we answer their questions? So I've given you an example of what an ideal referral would look like, addressing all these pieces. And the other thing that I'd like us to kind of be aware of is that ADHD has this idea in the culture that it ends at childhood. It's not a diagnosis of adults, but that's not true. And that's the case I'm hoping to make here. And so a lot of times I see people as adults because they were missed in childhood. Okay. And so the ADHD symptoms that we'll be talking about are difficulty regulating attention, emotions, And then not always, but commonly, people have a lot of extra energy in their body with hyperactivity and impulsivity. Okay, let's go to that next slide. So let's talk about me. So I'm a specialist in brain behavior relationships. I have a lot of training in neurosciences, neuroanatomy, in addition to psychopathology. And it's important for you guys to know this because these are all the disciplines I'm pulling from to be able to make these diagnostic clarifications, okay? Next slide. So when I'm using my tools, I'm going to be answering these top 4 categories for you guys. The bottom 2 is not something we can do at CCHP. So I can provide you with differential diagnosis, patient care and planning, helping with medical choices, helping you figure out how to communicate with patients, treatment planning. So if some people have an injury, like what do we do next? What are the next steps in treatment? And how do we study that progress? And then the last piece is the evaluation. Is this medication working? Are these treatments working? So we can see as a follow-up how things are going. And then the last piece is we support our work through research, and forensic neuropsychology is the medical legal piece of it that sometimes I get outside of my bounds when people's question is really about capacity and there's no medical question. And so then we have to refer to somebody who's actually a forensic neuropsychologist. Okay, let's go to the next slide. So what does a neuropsych assessment look like? It's actually a pretty intensive procedure. When you have a patient, we don't send every patient who has a headache for an MRI, right? So the same idea goes for if we have a patient who's complaining about ADHD, we don't want to send all of them to see me because it ends up being about 10 hours of my time. It's not just like an hour intake. It's a really intensive process. So I review their medical record. I look at past injuries. I look at medications, blood work. This is why I want this all up to date when I see them, because if there's other factors that I'm assessing, I don't want to be assessing poor sleep. I want them at their best. So I want to know that their blood work's all up to date. If they have past information, like past assessments, that's really helpful for me. These are the things that I'm reviewing. Okay. So then when I'm seeing them in person, I do an interview. I get a huge clinical history. And the introduction you give me really helps me springboard off of that. So I use your question to formulate my questions before I even see the patient. After the interview, we do in-person testing in my office in Oakland. And I test all different types of skills that you'll see on the right there. And then I put all the information I gathered together in a report. And I explain my clinical thinking, how I've ruled out other diagnoses, why this is the most likely one, why if I did consider it ADHD, I can't make that diagnosis. It's all in there because I use all of this data together to get to that point. I have a really solid diagnostic system. Okay. Next slide. Okay. So to think about ADHD in a neuropsych assessment, I want us first to think about these kids right here, because what we see is adults, but these are kids who have a diagnosis that starts in childhood. So we're seeing people who are long past the ability to be aided with interventions. So because ADHD is a neurodevelopmental condition, we have to see symptoms that start in childhood. And typically these symptoms that we're really seeing are things that are affecting their emotional ability, attention, and focus. And so that's what our testing is all about. That's what all the interviewing is about. How can we quantify those issues? Okay. Next slide, please. So this is the DSM diagnosis, the basic pieces of it. There's more info that we're going to look at on the next slide. But the main components is that it has to be neurodevelopmental. We have to see symptoms that are present before age 12. So if a patient says, hey, I think I have ADHD, and you go, hey, when did that start? And they're like, last week, or when this semester started, that doesn't tell me that it's neurodevelopmental. So maybe a follow-up question would help clarify that. But by and large, when we see that type of presentation, it's not ADHD. When we do have symptoms present, they're going to be apparent in 2 settings. We're going to see some type of functional involvement that interferes with your quality of schoolwork, work as an adult, or interpersonal functioning. So there are people having difficulty having relationships. And then the last piece is it's not better explained by something else like PTSD, some type of other medical diagnosis, a TBI, a sleep disorder. And I'll talk about some of the other co-occurring conditions as well. Okay, next slide. So these are all the symptoms that we look at. And so for inattention, we have to meet 5 of these symptoms to make the diagnosis. And not everybody has the bottom part, the hyperactivity, but you have to have 5 of those symptoms to meet that piece of the diagnosis. And when we talk about these symptoms, it's not a one-off. These are threads that we can follow throughout their lifetime. It crosses multiple places. It is significant enough that it's causing huge issues. So types of things that I'll see with some of these inattention symptoms. I was talking to a client one day about how he struggled in school. I said, tell me about that. And he said, I really struggled to do homework every night. I would be in my house reading one chapter for 3 hours. And that's a weird thing. It shouldn't take 3 hours every night for a simple task. And so with those of us who have ADHD, they have these types of stories where they needed extra support or they struggled alone for a very long time. It's not your job to figure all of that out, but I need some of the information to get me going. Okay. All right. Next slide, please. Okay. Oh, the one thing I should have said there too, ADHD is highly heritable. So you'll see the research is about 30% of those with ADHD have a first degree relative who also have the diagnosis or another neurodivergent diagnosis. So you'll often hear, oh, my son was diagnosed. And now learning about that with my son, it makes me really think about it. And I've been seeing so many similarities. Okay, so those are things that would help me clue in. This might be a good person to investigate. Okay, ADHD has 3 subtypes. We've got inattentive, hyperactive, and combined. In adults, we see less of the hyperactive subtype. There still are those who have the hyperactive subtype, but it tends to diminish as people get older. Some of us have just extra energy in our bodies our whole life, and some of us, it does change over time. The thing that the DSM doesn't acknowledge in their work is there's actually a lot of sensory processing difficulties and communication difficulties. So you'll hear a lot about stimming. I'm going to bring out some of my favorites that people have to use to help themselves pay attention. So I bet there's people on this call right now who are using stims wonderfully. They've got their mute on. And it's nice to have these tools to help us focus in, regulate our emotions. So if you're with a patient, some of the ways you'll see that is so some people are touching their hair a lot, moving their body a lot, those types of things. And then the communication issue is there's a hard time holding themselves in conversations. They get really bored. They get tired of conversations. They miss pieces of conversations because they're zoning out, right? And so this might be a patient that you've told the same thing to a number of times, and it seems simple, and you're feeling frustrated because you want them to thrive and you want them to do well. Okay, well, let me know what are the things that you two are struggling to get on the same page with. If you feel like if they adhere to this medical intervention, it would really make some big changes. Maybe like diabetes, maybe if there's other things that are really plaguing them that they're really having a hard time performing on. Okay, next page. Okay, so here's a myriad of co-occurring conditions that you'll also see. So one thing I want to highlight is those of us who have ADHD, particularly the hyperactive subtype, there's difficulties with evaluating risk-taking behaviors. And so we will see a high amount of issues with like traumatic brain injury, car accidents. So those are some of those through lines where we're seeing patterns of behavior that it's really hard to self-regulate, right? Other things that you will see are co-occurring thyroid dysfunction, sleep disorders. This is one of the things that's hardest for me that I would love if they could have a sleep evaluation, have that intervention first, because if they're not sleeping well and then they come in to see me, I'm not sure if I'm studying sleep or if I'm studying ADHD. So one person I got a referral for a couple weeks ago, she had a baby, within the last year, and then she had a traumatic brain injury a few months ago. And she has a lot of body pain and isn't sleeping well because her baby's getting up 3 times a night. That I can't test somebody like that because she's not sleeping enough for her to perform well in testing. So that type of person, we'd want to postpone the referral because she can't perform right now. So we'd want to evaluate that first. Okay, and then other things that we'll see co-occurring are the diagnoses on the right. The one I do want to highlight here is anxiety. A lot of us who have been missed, so a lot of us who are not white boys have been missed. Like, we don't see them, and so what we've been getting is a lot of feedback that we're lacking motivation, we're not keeping up, and so the secondary anxiety creeps up because there's been so many times of mismatches that they internalize their like inability to perform as a problem. Next slide. Okay. The next few slides, I'm not going to go through in depth, but I just want to show you that some of the work that I do and highlight, I try to bring in other materials to show patients that there are neurodivergent people who are thriving in life. And this clinician has some really great materials who kind of helps create information that's affirmative. And I'm working on my own abilities to talk about these things in a more affirmative language. And so when I'm giving feedback, that's part of my job. My intervention is to highlight the positive aspects, to use language that is user-friendly. And so for the patients to start to be able to identify the things that are hard for them so that they can communicate about it, so then they can focus on how do we respond to those needs. Okay, so next slide. ADHD and autism are highly comorbid. And so a lot of times when I'm looking at ADHD, I'm also considering autism as another neurodevelopmental disorder. The next slide. ADHD and PTSD are also very common, but they also might be, I'm teasing those apart. Sometimes people have PTSD, but it can also look like ADHD. The inattention can also, be just difficult to tease out. And so that's my job in these types of instances. So a lot of times I'll get a referral from a psychiatrist because they're not sure which thing is going on or which thing is more at play. And if we can address like maybe the PTSD, maybe the ADHD is more manageable, or maybe the ADHD isn't there. That's the type of thing that we're looking at. Okay, next slide. So I get this question a lot, and I wanted to take a moment just to say again, is there an epidemic? Is it on the rise? In my opinion, no, it's not on the rise, but there's been a few changes that have made it more likely that we're going to see these types of referrals. One of them is,
oh boy, all downstairs.
Brandon,
some of us need to mute. So the thing is, like I said before, a lot of us have been missed. So we haven't been in spaces where we've been looked at for ADHD, or we've been overlooked because of how we look or how we act. Maybe we have the ADHD inattentive subtype, but we don't have the hyperactivity symptoms. So we've been floating by, but just kind of white knuckling it through life. COVID has changed a lot of how people's work environments. And I believe that's really impacted how people are able to contain. Like, going to a job is very containing. You go work there, there's other people who are body doubling. But then when you work from home, all hell breaks loose. Okay, so no, I don't think there's an epidemic. All right.
Dr. Wortman, can I just time check? We're at about 20 minutes.
Oh, you are?
So
okay.
Want to make sure that folks have the opportunity to ask questions about perhaps clients that they're seeing. If there are other questions about referrals that may be sent over to you. I wonder if there aren't any questions, if based on what you were just saying, you might provide the group with your kind of working definition of body doubling and how that is helpful in ADHD, and how the lack of body doubling ultimately kind of brings symptoms to light. But please, folks on the call, if you do have questions, please jump in. We want to make sure they get answered.
Yeah, I'm happy to do that. I have a lot of resources, and a lot of this is self-explanatory. So body doubling is one of the terms that we start thinking like, okay, if I have a hard time containing myself, like having another peer might be a helpful way for me to be accountable. So it's not that they need to take care of me, but like we could have a mutually beneficial relationship where I will perform better if I know I can check in with somebody about that. So a lot of times I will help introduce the idea of like, let's tune into what your deficits are. What are the things that you have needs around is a better way to put it. Okay, well, I have a hard time managing time and thinking about time. So this thing right here is called a time timer. It helps visualize something that's like not tangible. It makes it more concrete. So bringing in some of these tools as part of the intervention, tools like that or medication are really helpful, but it's only half the battle. Therapy is a key component for the emotional regulation piece and undoing the years of being told you're not good enough. So therapy needs to be part of this picture. Do we have any questions? I don't want to just be rambling. Although I could just talk. I love neurodiverse folks. I really enjoy the energy. There's a lot of really exciting interests I get to learn about.
No, absolutely. And if there aren't questions, absolutely. I know that you have more slides. We can continue,
Yeah.
but did want to pause and just time check and
Yeah. No,
make
I'm
sure
glad you
that if folks want to jump in and raise hands, ask questions. But please go ahead.
Yeah. And so that's some of the things I'm looking for when I'm seeing these evaluations. I'm looking for like a start to that conversation. What does your cognitive profile look like? So a lot of times people have deficits in executive functioning. So that ability to plan, to organize yourself. It could also look like they do well on testing, but in daily life, they're just not hitting it the way they are. Some of these people will be in like 90th percentile, like genius level, amazing. But then in day-to-day life, they can't hold a job. They're not paying their bills on time. That disparity is very telling, and we need extra supports to make them to help them get to be more effective in their daily life. Okay, we'll go to the next slide.
And we have a question in the chat. I don't know if anyone wants to come off mute. It says, I would appreciate some tips on management in the primary care setting.
So like, how can we use ADHD tips in primary care settings? Okay, so one of the things I always say is writing stuff out. Having a visual and verbal is nice because you're encoding it two ways, and then putting it on the patient. What's the next step? How are you having them anticipate how they're going to complete that next task? Starting the conversation, just giving them something to do is hard for them. So having an extra question about planning is really, really useful for these patients.
Any follow-up clarification there from the?
The other thing I will say, you can keep typing questions. When you're making recommendations for therapy, ask them to find a therapist who works with ADHD. So a lot of people will do their job and go get a therapist, but if they don't have a therapist that has experience with ADHD, they're not going to be affirming. They're actually, sometimes it can be re-traumatizing because they'll talk about motivation. There's this whole thing in therapy where we do motivational interviewing, which is very helpful in some places, but it can actually be really harmful for those of us who have a lot of motivation, but just really have a hard time with the self-organization.
Dr. Wortman, if I can kind of distill some of the things that you've said to kind of answer this question as well in terms of management in the primary care setting, I think the tips that you recommended are wonderful, really, in terms of medical management for a number of conditions, right? Not just the ADHD, but how are you going to take care of your comorbid diabetes, what have you?
Yes.
I think that, you mentioned referrals to therapy and specifically kind of affirming therapists, but also, you talked about the management of untreated medical conditions, right, that may be contributing, right? The untested or untreated sleep apnea, the metabolic derangements. And then if, a trial of medication for the comorbid PTSD or anxiety or ADHD is going to be tried. You referred at the beginning of your presentation, to make referrals to mental health where some of those psychotropics can be considered. And after that trial, after the other medical workup, perhaps neuropsych testing might be indicated. But there's a lot of those preliminary steps that can be taken before sending to Dr. Wortman. Yeah,
because I'm seeing a lot of complex cases, and then it's easier for me to get to those complex cases if I don't have to filter through. And so that's the idea here, because I might be giving the same recommendation anyway, go see a therapist. So if they can get that treatment up front, and then if they're still having issues, then come see me. If people have already tried a bunch of things, then that's been established, that's fine for the referral. But we really want to make sure that the medical needs are being met, especially with like OSA. Like, if someone's having these anoxic events, they're really going to have memory problems, and there might be some recovery of those symptoms. And so that's like, let's treat that first, and then I can see if there's long-standing effects from untreated obstructive sleep apnea.
And for referring providers on the call, we'll get to this in one of the follow-up slides. From an authorization perspective, that is one of the questions that I commonly ask on receiving an authorization request, right? This is a member or a patient for whom, sleep apnea is documented as of concern and or known and untreated. Please clarify why, Dr. Wortman should evaluate with a full neuropsych battery prior to getting this patient on CPAP, for example. That inquiry is, again, a common clarifying question that I send to providers on reviewing these referrals.
Yeah, I think we can go to the making a referral slide just so you can kind of see that, because I think a lot of times what I would like to see is just kind of like, if you're having an issue with your treatment of this person or communicating, like, let me know. Like, that's the kind of thing that I would love to be able to help balance that with you, because you guys only have like 15 minutes with them. And so if I can make your job easier, that's a win in my book, because they see you guys the most. I really want to make sure that I'm helping you guys, so I can help with answering questions about how to manage like your meetings with them, about helping them, get on track with their medication regimen, those types of things. I can really help get to that next step.
Okay, so we're at 12, just about 12:30, unfortunately. I don't know, Dr. Wortman, if you have any final words to wrap up. I don't see any other questions in the chat or any hands raised.
Yeah. And, I know that cognitive questions can feel like really big. And I think just having one or two extra questions about the cognitive questions that we're having across diagnoses. When did this start? Like, what have other people told you? Those types of information is really helpful for me to see what's going on, because if it's just a recent thing and it's a stress-induced thing, we really want to be having them wait. But if it's been ongoing, they're losing keys, they're getting lost places, that's a real issue that we want to see sooner than later.
Well, great. Thank
Okay.
you. Thanks so much. If there are any additional questions, Dr. Wortman was very kind to share email addresses and phone numbers. So please feel free to reach out. Otherwise, thank you so much. Really appreciate your time. Very, very thorough presentation. Really appreciated it.
Thank you so much. Right.
Great. I'd like to now move on to behavioral health updates with our very own Dr. Barcelo.
Good afternoon, everyone. Nicolas Barcelo here, and kind of segueing from Dr. Wortman's presentation, we can go to that first slide and want to underscore, for neuropsych testing, we talked specifically today about ADHD, and everyone here on the call, we know that there are multiple indications for which neuropsych testing should be considered. We chose to emphasize ADHD because it has been, I think, a diagnosis, a challenging diagnosis, and we have seen, an uptick in some of the referrals received. And so we hope that that was helpful. But to kind of step back and broaden the conversation regarding other differentials, wanted to provide some very high level questions that contribute to our process of determining medical necessity, primarily for adults, when we receive these requests. And so echoing some of the questions that Dr. Wortman presented, when these are being reviewed, and these are kind of consistent with Medi-Cal guidelines for the Medi-Cal population, right? And are outlined in that non-specialty mental health provider manual. Happy to share that manual and these criteria with anyone. You feel free to email me. I can drop my email in the chat. But so the questions we're thinking about when making authorization decision, include what is the clinical concern, right? What is the medical management decision that is that is bringing up this referral request. And, if it is between two diagnoses, ultimately, do these diagnoses truly require that quantitative cognitive testing? Are they clinical diagnoses? Are these diagnoses that can be made by other means, or for which presumptive treatment has been attempted, and what we have is refractory case? Are there known conditions sufficient to account for the presentation? So, unless we're talking about an instance where there is, really a need for retesting because, for example, a medication, Aricept, psychotropic, has been initiated, if someone has known Alzheimer's, and I do see these cases, we're hoping to clarify why is it that they need neuropsych in the presence of a known diagnosis on stable treatment with, the appropriate imaging and preliminary testing in, for example, a neurology clinic. I won't read each and every one, but I think that it, again, is consistent with what was shared in terms of preliminary steps, comorbid conditions, and, in terms of authorizations, why should neuropsych testing precede other medical interventions that may or may not require auth, but that would be evidence-based based on the known underlying disorders. So any questions regarding that auth process for medical necessity around neuropsych, not just for ADHD, but for other conditions as well? Okay, next slide, please. So just a couple reminders regarding access to mild and moderate mental health services. This is kind of your bread and butter outpatient psychotherapy and psychiatry. A reminder that CCHP has transitioned to a place where these services do not require authorization from the plan. So neither PCPs nor outpatient mental health providers need to send auth requests. For the initiation of services, in order to support members in accessing those services, there are multiple options. Providers can send referrals either to, for example, their internal systems, right, to your colleagues who are integrated behaviorists without need to contact us, or can send referrals via the portal, right, the online platform, to the access line. The access line is a member-facing call center, essentially, that connects members with providers. Again, that is not an authorization request. That is simply a referral to connect members to providers. Finally, members can take it upon themselves to call access at their own time, and at which time they will go through a screening to determine what is the appropriate level of support to provide. For any mental health providers on the call, a brief reminder that if you are seeing a member in that mild to moderate system and you would like to transition their care to a higher level of care and or add services in the specialty mental health system, we will be looking for a transition of care tool. If a member calls access requesting that movement to specialty mental health and we see that they are open to non-specialty mental health, we will reach out to you as the provider and again request that transition of care tool. That training has been provided and is available on the portal if anyone needs refreshers. But again, please feel free to reach out if there are lingering questions. Next slide, please. With regard to behavioral health treatment, and this refers to services generally related to autism, including CDEs and ABA, a reminder that authorization is required. And we, are reviewing those auth requests in standard timeframes, generally between 5 and no greater than 14 days. We are working with community health workers and case managers to really support members in ensuring that they access these sensitive services. If you have concerns about any of your patients receiving CDE or getting connected to an ABA provider, please reach out. To ensure the value add of the case management and CHW that we are providing, we are conducting an internal audit. We want to make sure that when you submit a referral for CDE, you receive that result back and that you are made aware that, there are lingering items that can be acted upon in terms of getting this young person to the needed services. Next slide, please. Finally, a notification regarding auth expectations and requirements. CCHP BHD will be, following suit and operating consistent with expectations in auth which includes identification from the referring provider of to whom they are referring. And so if we receive a referral that does not have a designated provider for neuropsych or CDE, we will send it back asking the referring provider to identify to whom they are referring. And referrals missing that information would not be processed for approval thereafter. And so again, we are looking for that information in ways that are consistent with all of the authorization processes happening here at CCHP. And the anticipated go live for that with neuropsych and CDE is coming at the end of Q2. So start of Q3. I think that's my last slide. Happy to take any questions. Okay, thank you all so much. I'll hand it back to Dr. Lowe.
Great. Thank you, Dr. Barcelo. So our next slide is quality updates. Elizabeth Hernandez, our quality director, is away today, so I will be substituting and stepping into her shoes. So the first slide that I really wanted to share with everyone is a discussion on timely access to care. As a health plan, CCHP is beholden to the state in making sure that our members are able to reach certain providers in certain situations within a timely period of time. So all California residents have a right to timely access to appointments according to the following timeline. So for urgent care, where prior auth is not required by a health plan, it's 48 hours. If prior authorization is required, it's 96 hours. And then there's different timelines for non-urgent care and follow-up care. So we just wanted to remind all of our providers about these timely access standards that are dictated by the state. Now, of note, sometimes these timelines are very short and sometimes difficult to really maintain and fulfill in real time. Appointment timeframes can be shortened and extended as clinically appropriate. However, as a referring provider, if you feel that the timeframe can be extended, it needs to be documented within the member's medical record that it is not detrimental to the member's health. And also the provider must notify member of their right to file a grievance if timely access standards are not met. Next slide. So I also wanted to say a little bit about initial health appointments. So this is really in order to establish care for patients that are newly enrolled in Medi-Cal. Per Medi-Cal guidelines, new Medicaid members should have an initial health appointment, also known as an IHA, completed within 120 days from plan enrollment in order to establish care. And at minimum, this initial health appointment must include the following: a physical and mental health history, identification of risks, an assessment of need for preventive screening or services, individual health education, diagnosis, and plan for treatment of any diseases. So very important that this must be completed within 120 days from plan enrollment for our Medi-Cal members. Next slide. Finally, I wanted to share with everyone some shared decision-making tools. And these are tools that are a collaboration between patients and providers so that some decisions can be made regarding tests, treatments, and care plans. So we wanted to share some resources from your practice, as well as additional information on shared decision-making and that approach. Any questions on this? Great. Next slide, please. I'd now like to turn over to Dr. Levin, our medical director for CalAIM, for some information regarding transitional care services. Dr. Levin, is all yours.
Thank you. Good afternoon. I just have a few slides regarding the transitional care services that are a requirement to provide a 30-day episode of transitional care in any time that a member transfers from one setting or level of care to another. So hospital discharges, psychiatric inpatient discharges, residential treatment discharges from skilled nursing facilities are all included here. And the idea is to support members as they transition to transition to the least restrictive level of care that meets their needs and is aligned with their preferences. And then the idea is that the case manager providing the transitional care services provides the support and coordination needed to have a safe and secure transition by connecting them to community supports and services that make them successful in whatever the new environment that they're transitioning to with the least burden possible on the member. And although we are there, there's for the highest risk transitioning members are required to have a single point of contact and a case manager assigned. Transitional care services are available to all members regardless, and at any transition, they should be made aware of their access to our case management services at the health plan to contact for transitional care services. Next slide, please. And the goals are really prevention of readmission, of institutionalization or reinstitutionalization, and or in the case of hospitalization or inpatient related to chemical dependency and or to psychiatric illness to prevent relapse. And the idea is to identify appropriate for our members that are in custodial care in institutionalized settings such as SNFs. There's another part of transitional care, which is trying to transition members who want to back to the community and can be transitioned safely. And then ensure timely, high quality, relevant care and services in the vulnerable period after a transition. Next slide, please. And this is just sort of a schema on sort of how it works and who's responsible. Our responsibilities as a plan is really to notify, is to be notified of all admissions, discharges, and transfers so that we can activate these services for our members and or connect them to if they are enrolled in enhanced care management, to their case manager who will provide for the transitional care services, which is a 30-day episode. So for the high risk, they must have a single point of contact. And we do have a team on our case management department of case managers who are exclusively working with members in their transitional period. And the role of the care manager for the high risk is coordination with the discharging facility. So starting hopefully before they're actually discharged, ensure that the discharge planning document is shared with the patient, the primary care provider, and other providers. Ensure that the follow-up doctor appointments, medication reconciliation, and referrals are completed within that 30-day period. There's some, the medication reconciliation is supposed to happen within the first week. And then at the end of services, which is that 30-day period, to arrange for longer term care management if that is indicated, and or any community supports that they may be eligible for. Although this state does call out sort of certain populations that are high risk by default, anytime the discharging facility can assess someone to be a higher risk and request case management services and an assignment of a single point of contact with a case manager. And again, the idea is that this occurs in that 30 days post discharge and is coordinating and ensuring follow-up of services and referring to services if eligible. Next slide. I think that might be it. This is just the referral portal, what it looks like when if you're referring through the portal, the order for case management referral, and you'll see those transitional care services that you can select. If the phone number we have asked all of our contracted facilities to ensure goes on the discharge paperwork is our case management follow-up number that has at the beginning of its phone tree a bypass to go directly if you're recently being discharged from a hospital. And then we can always receive fax referrals as well. Next slide. Yeah, I think that's it. So I'm happy to answer any questions if there are any. All right.
Great. Thank you, Dr. Levin. I did notice that there are a couple questions regarding the IHA slides. I'm going to take that back to our quality director so that way I can give you correct answers. So we will provide that follow-up once I'm able to connect with her on your questions, but thank you for asking. For those who weren't aware, the questions are, what if a patient is new to Medi-Cal but is established and has already had an annual physical? And the other question was, is there a draft letter to send to new and established patients, emphasizing the importance and encouraging them to come for IHA? So I'll get some additional information and make sure that I share that with our providers. Our next speaker is Suzanne Sang, and she's our Director of Member Services, and she will be speaking about the Medi-Cal transportation benefit.
Hi, everyone. Next slide. So as an introduction, Medi-Cal has a transportation benefit. It is only for members without any other means of getting to their Medi-Cal covered service. So if they normally are able to get to their appointments on their own or through the assistance of a family member without any issue, the benefit should not be available to them. But if they have trouble otherwise getting to their appointment, this is a service they could access. Medi-Cal service means that it generates a Medi-Cal claim. So keep that in mind when you're wondering whether or not a certain type of ride is covered. We've listed our transportation line above. If the member forgets, they can also access this line through our member services line. They just have to listen through the prompts. There are two types of transportation. The first one is called non-medical transportation. It's for members who could get in and out of a car sedan or who can use paratransit. So this is people who use paratransit, bus, Lyft, Uber, or taxi. The second type of transportation that's offered under this benefit is non-emergency medical transportation, or NEMT as an acronym. And that's for non-ambulatory members who are unable to safely take NMT, the non-medical transportation I just discussed. This refers to wheelchair vans, the gurney or litter van, or non-emergency basic life support ambulance, as well as air. So we're focusing today's discussion is focused on the NEMT part of the benefit. Next slide. Can click through. So again, the non-emergency medical transportation benefit consists of the wheelchair van, gurney, litter van, BLS ambulance, and air transportation. And again, it's for members who cannot safely take NMT. So if they use crutches or not, or maybe they're not registered for paratransit, they have altered mental status, they have shortness of breath requiring oxygen, that's when this would be appropriate. Next slide. So I'm going to go through all the different modes of transportation. The wheelchair van, for this mode of transportation, it's for members who are incapable of sitting in a car or public transportation for the period of time needed for their transportation, or they require a wheelchair and assistance to and from their residence or vehicle and the place of treatment because of a disabling physical or mental limitation. It requires safety equipment above what's in a car or other public transportation. An example is if someone uses the wheelchair, if they have altered mental status, or they need oxygen without monitoring. So there's notation about like whether or not dialysis is sufficient. Like sometimes what we've seen is that people might be fine going in a sedan on the way to dialysis, but then on the way back, they might need a lot of assistance and are unsteady, and it might be unsafe for them to use a regular sedan, and a taxi wouldn't be appropriate. So in that case, make a notation about the rationale for the need for a wheelchair van. Next slide. A gurney, that's for members who require transportation in a prone or supine position. They cannot sit or are bedbound. They're non-ambulatory and cannot use a wheelchair. Next slide. And the next level up is the basic life support BLS ambulance. These are for members who need, who are new on oxygen, have a chronic condition with oxygen monitoring, are on IV meds, or have need medical monitoring, or if there is a need for transportation between 2 inpatient healthcare facilities, this is the only transportation option. Same thing with transfer between facilities requiring observation. Next slide. So what's important about NEMT that is the biggest distinction, a big distinction from NMT, is that it requires a prior authorization prior to booking a ride. So it requires both a prior authorization, what's called a physician certification statement form, PCS form. And in order to produce this, in order to provide this for the health plan, you would submit this through CC-Link or the provider portal. You can submit it for up to a period of 1 year. So you can estimate the number of rides that a member might need for the entire year, count the round trip rides. So if they need, 2 rides a week for a month, like you would multiply 2 times 4. So you can estimate that for the year. You'll have to indicate the mode that's requested, the mode of transportation that the member needs, and the justification about why the member needs the NEMT. The certification statement has to be submitted by a prescriber, so a MD, DO, NP, PA, dentist, podiatrist, mental health professional, SUD treatment professional, etc. Next slide. So the NEMT prior authorization process, just some information on here about the average turnaround times. Dr. Lowe had gone through the regulatory standpoint of the turnaround times, but on average, the CCHP turns around our prior auths within 72 hours if it's urgent, or 5 business days if it's routine. We take into account if it's an emergency, we try to meet the needs of the member. If providers need assistance, they can contact the CCHP provider line and reach UM. And if the clinical criteria is met, just like any other prior authorization, you'll get the provider who made the request will get notification, as well as the member. The lowest type of NEMT service that will meet the member's need is what will be approved. And that's determined by the medical professional who's making the request. Next. Oh, so we need all this information before you make the request. Next slide. So the transportation hotline that we had mentioned early on is available 24/7 for both members as well as providers, and this is for NEMT. We do request that people make the ride requests 7 to 10 business days in advance, but we also understand there's urgent needs that come up, in less than in that time frame. So just request it as soon as possible. If it's urgent, we understand that happens sometimes as well. If it's an emergency, don't use the service. You're supposed to just call 911. So we do want to make that distinction. But if NEMT is appropriate, just make sure you have all the details ready about what the requests, about the address, pickup location and drop-off location, the date and time of appointment, the length of the appointment, and requested mode of transportation. Our agents will assist with conducting the intake and take down all the details and assist with making the ride arrangements. The NEMT prior authorization and PCS form must be on file. So if it's not on file, someone may reach out to the provider to request it. So we could use your help in making sure that that's in place for the member. If we're unable to confirm the appointment with the member, we might not arrange the NEMT just because it's costly. And if we find out like the member wasn't not able to make the appointment, we want to avoid having a unused ride. And then we also want to remind people to call CCHP to cancel the ride if there's a need to cancel or reschedule appointments. If there are any challenges, contact the transportation line and discuss it with the agent on the other end. Next slide. And that's it from my portion. Dr. Lowe, I don't know if you want to go through the process of submitting.
Sure.
Okay.
No, absolutely. Thank you, Suzanne. I mean, I think the most important thing that many of our providers may not know is that NEMT is offered for our Medi-Cal members. So definitely a resource that not many people know about and really want, our providers to be aware. So that way our members can easily get to appointments if needed and if appropriate. So, as Suzanne mentioned, the order for NEMT needs to be submitted via our CC Link provider portal. Next slide. So we put together some screenshots that kind of show you how you enter in the orders. You open the form for an order, you type in the name or medical record number. Next slide. You select the patient and then you add the order. Next slide. And the order is specifically NEMT. And then next slide. You'll get kind of a screen that asks you for a lot of pertinent information that is needed. Specifically, you need to indicate a reason for NEMT, and you need to enter the date range. Next slide. And then you also need to indicate the mode and the reason. And please describe that in detail because we do need to review these rides according to Medi-Cal guidelines in order to determine whether these rides are medically appropriate. For example, with a gurney request, oftentimes if someone's bedbound, that sounds appropriate. But if someone's able to sit in a wheelchair, then, a gurney would not necessarily be appropriate. And then, a wheelchair may be more appropriate in that instance. Next slide. And then you accept and sign the orders. Next slide. Oh, stay here. And then, hopefully, we'll get the request at CCHP. We will review and provide authorization or ask for additional information or deny according to our guidelines. I do want to again emphasize how important the physician certification statement is. That is a Medi-Cal requirement. CCHP cannot process a request for NEMT without that form. So we will ask for that form if that is not supplied. The form is a very busy form, I will admit. And, but, I think when you look at the form, there are key areas that do need to be completed. And as Suzanne mentioned earlier, we do need a signature for the PCS form to be completed. I do not think that the cosign, someone's asking if the cosign is considered the certification statement. I'm not quite sure what the cosign you're referring to is. The PCS form is a form. All right. Any questions on what we've shared? Wonderful. Next slide. I'll now turn it over to Stephanie Schramm, who is our director for case management, and she's going to talk more about community health workers. Stephanie, all yours.
Good afternoon, everybody. We're almost at the end of the tunnel, so thank you for bearing with us for as long as you have. I'm Stephanie Schramm. I'm the director for case management at the Contra Costa Health Plan. And I want to take a few minutes to chat with you about a fairly new benefit to the Medi-Cal member known as the community health worker. Community health workers are actually a pretty good idea for a lot of different reasons. And the primary reason is that they help people negotiate barriers and they have lived experience that is in alignment with the member's lived experience. So They can help troubleshoot and provide a level of understanding and guidance and support that sometimes people who don't have that shared life experience just can't do. Community health workers are trained as health educators, and they work directly with the clients to to work through things like cultural and language barriers, which does seem to be a fairly formidable problem for some of our members. They can assist individuals by helping them navigate the relationship with their healthcare providers and accessing the services that they need to take care of their health and to access what they need to get accessed. Community health workers also encourage early detection of disease through health education, encouraging the member to go get their screenings done, helping them make their appointments, even going to some of those appointments to be an extra set of ears, just to keep folks out of the emergency room for things that they don't need the emergency room for. Next slide. Health education, community health workers, health education, helping folks understand and navigate the healthcare network and stressing the importance of things like prevention, immunizations, prenatal care, all of the things that help keep folks out of trouble. They also help as I said, they also help our members navigate the healthcare system. They encourage the screenings and assessments that need to be done as part of regular routine healthcare. They also offer individual support and advocacy. And again, I really want to stress the importance of the life experience requirement for community health workers, because it's very difficult, I think, for some people to admit that they're having problems getting something done because of an issue that a lot of people don't understand. So whether that's language, whether that's cultural, whether that's fear of healthcare, a lot of folks coming out of who are being released from corrections, have a hard time accessing healthcare. So having people attached to them that are very close to the community, that understand their path and the barriers that they are facing, will help them get where they need to go and help us take care of them. Next slide. So here's the criteria for the community health workers. And again, we're going back to that lived experience thing. So incarceration, disability, mental health conditions, homelessness, cultural background, substance abuse, shared race, foster care placement is really getting a lot of attention now as well, military service, pregnancy and birth, survival of violence and abuse exploitation. So I think that one is especially sensitive, and having somebody with you who understands that journey is invaluable. Shared gender identity, shared language, this helps the community health worker assess individual needs and work with the member to establish the needed health access. Just being able to understand the path that the member is on is invaluable to getting them where they need to go. Next slide, please. So there is criteria for a community health worker outside of lived experience. There are some required qualifications. So there's this, they are required to have or be eligible for a CHW certification. And those are academic programs. The one in Contra Costa County is attached to Diablo Valley College. Some of our community-based organizations have other programs for community health workers in places like in academic institutions like Turo. So they're popping up. And the demand for the community health worker is getting bigger and bigger by the second. So the CHW certificate, the lived experience, the CHW certificate, and there's also a violence prevention certificate that the CHW is highly encouraged to pick up on. Also offered through the designated academic programs at DVC and throughout the community. The work experience pathway is actually a very interesting idea, because a lot of our community-based organizations have folks already employed with them that are doing this work. They're just not titled the community health workers. So rather than send them through an academic program, if the employer can document and demonstrate 2,000 hours of CHW work in the last 3 years, that bypasses the CHW certificate academic qualification. As attached to the program, they have 6 hours of additional training 6 hours of additional training that they need to go through every year to keep them up to speed on the stuff that they need to know. They are not required to enroll as Medi-Cal providers. Most of them do not build Medi-Cal individually. They work for organizations that do. Next slide. So the referral process through the portal, just like everything else is, and it's under case management and CHW, and then fill out the form and send it off. Next slide. So here's what, when you ask for a CHW, here's what's covered. The initial referral covers 4 6-hour blocks per member for any community health worker provider. So it's 6 hours per member for the initial referral. And we can get a lot of stuff done in 6 hours. Additional hours are available, of course, but they do require an authorization from UM and a referral from a medical provider to establish medical necessity for the service. And then it goes through UM and it's not painful. Claims to CCHP must be submitted by a Medi-Cal enrolled supervising provider. Because the CHWs do require supervision, their employers are the ones that will file the claims for them. Next slide, please. So are there any questions about community health workers? Let me see.
So Stephanie, there's a question in the chat that says for the work experience pathway, what does that documentation look like? Where can we learn more information about this?
It's on the community health worker website through DHCS. And what it looks like is that employers like RISE, like I said, many of the community-based organizations already have folks that actually act as advocates in these roles. And the employer is required to provide either payroll records or some educational records on the hours that the community health worker has been doing this work in order to get that designation and be able to bill for that level of service. Does that answer the question?
Yeah, what I'd also like to add, Stephanie, is that, I think it's great that there's this work experience pathway, but I do think that they're moving more and more towards a certification, really to, provide documentation for what, what is needed and what kind of services you're actually getting from someone within their training. So I think, I think it's fantastic that we have this benefit, and I think additional clarification will obviously come as we, have more and more community health workers doing the good work.
Right.
Thank you.
So
yeah.
I'm sorry, as with any new benefit, that if we recognize that there are folks that are out there already doing the work, it's not uncommon to institute some sort of grandfathering in to address Dr. Lowe's point. Yes, we obviously prefer the certification, but we're giving this opportunity to folks who've been doing the work for a long time.
Great. Thank you so much. Any
You're
additional
welcome.
questions for Stephanie? All right. Hearing none, I'll turn it over to Erin Mellis, who is our Director of Operations here at CCHP, so she can provide some additional information about our provider disputes and claims. I'll turn it over to you, Erin.
Great. Thank you, Dr. Lowe. Good afternoon, everybody. Not sure if my camera is working. Did it switch over to me?
Yes, it did.
Awesome. Okay. I'm not seeing myself. I was only seeing Dr. Lowe, so I wasn't sure if it came over to me. Thank you so much, Dr. Levine. So just wanted to give everyone some information today on our provider dispute resolution process for those of you who are not aware. So claim disputes can be submitted on claim denials for underpayments, overpayments, for authorizations, or other billing and or reimbursement issues. Claim disputes should be submitted within 365 days from the last determination date. And those requests for considerations should accompany any supporting documentation that you might have related to that dispute. So if you're disputing for any kind of authorization, and you should put any documentation such as office notes or any type of documentation that would support the overturn of whatever that denial was for. If your whatever the actual claim denial was for, if you are seeking payment that requires a invoice, if you need some sort of office notes or some sort of documentation to support a denial, then that documentation would be required in order to overturn that specific denial. Then that documentation should be attached to the dispute in order to facilitate the payment of that claim and the consideration for payment. You are able to upload that information with your submission of the provider dispute via our portal. Obviously, we encourage you to do that. That is the quickest way to get that submitted and quickest way to get a determination. And we have provided the link in the presentation here today. You can also submit your disputes via certified mail, and we've provided that address here. Any questions related to provider disputes? Does include case where a patient was not assigned for some reason. The provider disputes would only be for claim denials. So if a patient was not assigned to us for some reason, then those requests should go through our member services area, not through a provider dispute. Hopefully that answered your question. Yeah, thank you, Dr. Lowe. Yeah. So the more details on the appeals and grievances will be a little bit later in the presentation. So if we can go to the next slide, thank you. So in relation to claim submissions, our claim unit ensures the timely payment of clean claims with primary responsibility, including claim processing, responding to claim inquiries, and returning claims to the provider if there's missing information. So Availity is our EDI clearinghouse, and to submit EDI claims, please register with Availity, and we've provided the link to be able to do that with the following CCHP payer ID. And then providers must sign up for CCHP's CC Link provider portal to review claim status and submit claims where appropriate. So those tools are available for you on our provider portal, and that gives you easy access to review the claim status. And that's, again, the quickest way for you to review status of your claims, submit those provider disputes, as well as you can submit claims there. And Availity, again, is a way for you to submit your claims through an EDI clearinghouse as well. You can visit the link there in order to sign up for our provider portal and complete that provider portal access agreement form, and then email that to the CCH portal support. And then if you've already signed up for that portal access, you can reference the website for instructions regarding submission of your claims. If you must submit paper claims, you can mail those to the following PO box. And then a reminder, just check your original claim status before calling or submitting duplicate claims. Again, duplicate claims can create unnecessary work for all parties involved. And it creates a, significant backlog for us, which just creates then a delay for your claims payment as well. So if you have not received payment within 45 days, you can call CCHP to check claim status. Again, the best way to check status on your claims is to go to your CC Link provider portal for the fastest response. Any questions on claims and submission?
Great. Thank you so much, Erin.
Thank you, guys.
All right, I am the last presentation of the day, so thank you everyone for bearing with us. Really wanted to share a lot of information with you today. So just the outline for my CMO updates, just wanted to give an update on our 2024 transitions, provide some updates on authorizations and utilization management, and also just provide a refresher on our members' appeals and member grievances processes. Next slide. Next slide. So as we all are fully aware, I've brought this up almost, I think, at every provider network training I've done so far, is we've had a multitude of populations that have transitioned to Contra Costa Health Plan as of Jan 1, 2024. So of course, we became a single plan model here in Contra Costa County. So all of the Anthem Blue Cross Medi-Cal members became ours on Jan 1. We also carved in additional long-term care benefits, such as intermediate care facilities for the developmentally disabled, as well as the adult and pediatric subacute care facilities. We also saw the adult expansion of undocumented individuals ages 26 through 49. And in addition, we also see on a monthly basis members transitioning from fee-for-service Medi-Cal to managed Medi-Cal with CCHP. So what have we been doing? So we've been doing a lot of communicating, a lot of collaborating, and a lot of maintaining of continuity of care. So we have spoken with our providers and our members before, during, and after the transition, and we've used these different mechanisms to share information. And frankly, we've learned a lot through the process. We've learned that not everyone gets information through any of these means. So we really do need to look at our modes of communication and really determine how best we can share information with our providers. As our membership has grown, our provider network has also grown. So we really want to be able to get the information to where it needs to go when it needs to get there. A huge component of transitions has been maintaining continuity of care. We've created a large number of policies and procedures and workflows to help with this continuity of care management. And we have also ensured that our staff on all levels has received training so that we can maintain the continuity of care for our new members. Next slide. Now wanted to kind of provide some refresher and some updates on our authorization and utilization management department. As I previously shared, the following changes were effective on November 1st, with the caveats that the service must be completed within the patient's network for authorization not to be required, and that it also must be completed with a contracted CCHP provider. Any services performed outside of the patient's network or with a non-contracted provider, or whether it's a tertiary provider, will also always require prior authorization. Next slide. So we've made some enhancements in our prior authorization requests for certain visits. So, our move is really to, improve the workflow and processes within our providers' offices, really decrease the workload for our providers and their teams, as well as increase access, most importantly, for our members, your patients, and also decrease the workload for our CCHP staff as well. So as of November 1st, 2023, consults and follow-ups for all specialties except for neurosurgery and transgender services will no longer require authorization. Any procedures or surgeries will require authorization, and bariatric surgery consults and follow-ups will no longer require authorization, but the procedures themselves will require authorization. And also wanted to highlight pain management. Pain management consultations and follow-ups will no longer require authorization, but procedures will continue to require prior auth. And again, this is all in the context of the caveats I mentioned earlier, where it must be with a contracted in-network provider in order for no prior authorization to be needed. Any questions on this? Great. Next slide. I also wanted to provide everyone with a refresher as to how they should contact our utilization management team should there be any issues or concerns. If you have any general questions, you can reach out to our CCHP AuthUM department at this email address or call the provider call center at this telephone number. If you encounter situations that are more urgent or you find that you need to escalate an issue, please feel free to email this other additional email address, which contains our leadership. Please be judicious in utilization of these email addresses. Our goal is to be responsive and to provide information and responses that are needed, but we want to be able to triage accordingly. All right, next slide, please. So I also wanted to give everyone a refresher on our member appeals and member grievances processes, especially, in the context of Erin having provided additional information about provider disputes. Instead of being from the provider's perspective, appeals and grievances are from the member perspective. So if a member is dissatisfied with the service that is provided by a provider, they are able to file a complaint or a grievance. And if a member believes that a service or payment for a service has been denied, deferred, or modified inappropriately, they may submit a member appeal. Next slide. So these are the ways to file a grievance or appeal. A member can call member services. They can also write about the issue and mail or fax it, and then they can also submit an online form. Next slide. If a member wants someone else, such as a family member or friend, to help them file a grievance or appeal, CCHP would need to contact that member for verbal permission. And also providers can file a member appeal on behalf of their patients. However, the provider would need to submit a signed member consent form to file the appeal, and that form is available at this link. Next slide. So just wanted to give everyone an inside look at what our process is once we are aware of a grievance or appeal. Once we have taken in a grievance or appeal, we will send a member a letter of acknowledgement to inform them that CCHP has received their grievance or appeal. CCHP will then review and resolve that case within 30 calendar days. Next slide. Now, I would like to point out that there are instances where a grievance or appeal may be expedited. And so in this situation, a member can ask CCHP for an expedited review within 72 hours when they file a grievance. The plan will provide an expedited review if waiting 30 days for a resolution could seriously harm the health, life, limb of the member. And for cases that required actual expedited review, the plan will make a decision no later than 72 hours after the request is received. If we decide to downgrade the grievance or appeal from expedited to routine, we will notify the member and then we will follow our usual processes. Next slide. Any questions on that? Wonderful. Next slide. Well, thank you everyone for attending our Q2 2024 provider network training. As always, we will be sending out a link and slides for our presentations today. And also we always welcome feedback and any ideas or about any topics or concepts or programs that you'd like more information on. So please share if you have anything that you'd like us to address. Otherwise, we have 6 minutes left, so just wanted to ask if anyone has any other additional questions before we let everyone go for the afternoon. All right. Well, hearing none, thank you again. Have a wonderful day.